So I'll kick us off. Thank you very much. It's 4 o'clock, and welcome to our Greater Manchester ARRS Employers webinar series. My name's Alison Lee. I'm a GP, and I'm here as the Clinical Director for Primary Care Workforce for Greater Manchester. I'd like to introduce the team that we have today, if that's okay. Natasha.
Hi everyone, I'm Natasha Odita. I'm a Primary Care Workforce Programme Manager at the Partnership.
Alison.
Alison Pritchard. I am the Specialty Training Lead for Pharmacy Technicians and Pharmacy Support Staff for Health Education England.
Thanks, Alison. And Rob, do you want to say hello?
Yeah, hi, I'm Rob Harris. I'm Project Administrator at the Greater Manchester Training Club.
Thanks, Rob. And Liam. Liam is on the slides today. Do you want to say hello, Liam?
Afternoon. Liam Jenyon, responsible for the comms and media at the Greater Manchester Training Hub.
Thank you. We will be joined by Kate Cattrall, who is our HE Physician Associate Workforce Lead, and we are lucky enough to be joined from the national team. Peter Tyndall and Jeanette Summers will be joining us later. Do you want to say hello, Peter?
Yeah, I think Janet's here as well already. Yeah, I'm Peter Tyndall. I'm Head of Planning and Performance and Planning for the NHSEI Primary Care Workforce team, and our part of the team oversees the additional roles.
Thanks, Peter. I don't want to bring you in too soon, but Janet, do you want to say hello?
Yeah, hi, Janet Summers. I'm a Programme Manager in the Primary Care Workforce team, and as Peter has mentioned, we work on the additional roles and the MDT, working towards the 26K. Thanks so much. So just a bit of housekeeping then, if that's all right. We are recording this webinar for use at a later date. It will be edited by our in-house tech team. So just to let you know, this meeting is being recorded. We very much welcome interaction. So if you want to ask questions, either type in the chat that's being monitored or raise your hand. That would be amazing. As always, feedback is exceptionally important to us, and we are tweaking these webinars as we go along. So if you have any feedback for us, please let us know, and there will be a short feedback questionnaire at the end. So thank you very much for that. We have two speakers today and then a Q&A session. We've got Alison Pritchard up first, followed by Kate Cattrall talking about physician associates. There'll be plenty of time for questions at the end. So may I kindly hand over to Alison Pritchard to talk about pharmacy technicians. Thanks so much.
Thank you very much, Alison. Obviously, I'm Alison Pritchard. I'm a Specialty Training Lead for Pharmacy Technicians and Pharmacy Support Staff working for HEE across the North West. So just to give you a little bit about my background, I'm a qualified registered pharmacy technician. I have been for approximately 30 years now. So I've seen lots of things change, either within sort of primary care sector or secondary care sector as well. So I've done lots of things around education and training, assessing, working in secondary care, working in community pharmacy, etc. So I've seen lots of different ways of working for pharmacy staff and the impact it has on the wider community, i.e. the patient. Okay, next slide please, Liam. Thought it'd be quite useful just to give you a bit of an insight really into a pharmacy technician and what we can actually offer for the primary care networks out there. So it's a person who holds a pharmacy technician qualification, and it's recognised by a regulatory body, which is the General Pharmaceutical Council, which is the same regulatory body as pharmacists. So we've been a registered profession now for quite a few years after a very long debate over whether we should be registered or not. So that is actually happening now. There are approximately 25,000 of us within the United Kingdom. Obviously, you can search any of us up on the GPHC register. We do have to undertake CPD and pay an annual registration fee in line with other professions. And I think it's fair to say that we're a key team member, not only within the pharmacy team, but also in the wider multi-professional team as well. So certainly in my career, I've seen the role of a pharmacy technician change from a dispensing role, which we have assistants who dispense now, right through now to doing the final accuracy check on a prescription, having clinical roles, management roles, teaching roles and leadership roles as well. So a huge variety of roles. So we're not to be confused with an unregistered workforce. We do have a large proportion of staff who aren't registered yet. Next slide, please, Liam. Okay, so why should you employ a pharmacy technician? What do we have to offer? Well, I was really pleased to see the new GP contract and the fact that pharmacy technicians got a mention in there as well. And as you know, PCNs are tasked with delivering seven national service specifications, so around medication reviews, medicines optimization, personalised care, long-term conditions, etc., tackling neighbourhood inequality, cardiovascular disease, etc. We can effectively support GP surgeries, PCNs and care homes in the delivery of all of these areas. We've got pharmacy technicians who predominantly, when we think of pharmacy technicians, they're working in a secondary care environment, and I think we've kind of created a bit of a silo there really, which is unfortunate. And I think certainly what we've done within the Northwest is we've started to promote pharmacy technicians and actually put placements within GP surgeries, within the newly developed PCNs and care homes. We've got pharmacy technicians working in the ambulance service now as well. We're advocates of medicines optimization. That is what we do. We work along our pharmacists. A lot of the pharmacist roles have now been passed on to pharmacy technicians. And as long as we all work within the correct guidelines and procedures, then pharmacy technicians are undertaking more and more responsibility. We are multi-professional team workers, so we're used to working with GPs, with doctors on wards, for example. We're used to working with the ambulance service, care homes. We're providing domiciliary visits now as well, making sure patients get the best out of their medication. And I think it's really important that the acute sector and the primary care sector develop a stronger collaboration. Very often, we will see admissions, say, into a secondary care environment that perhaps could have been prevented with improved concordance and compliance of medicine. So medicine seems to be the hub of activity, and that's something that we can actually have an impact on as a profession. Next slide, please, Liam. So what sort of roles can we undertake within primary care settings? We've been piloting the roles of pharmacy technicians within primary care now within the Northwest for the last 4 or 5 years, and things have really started to improve within the last 2 years in particular. We've invested quite a bit of money into training of pharmacy technicians so they can reauthorise repeat prescriptions, they can review patient medication records. That can involve audit and review as well. So we've got medication review dates that we can look at, can align medication repeat items. How many patients do you know that have a huge stockpile of medication at home? So we can align supply and we can have an impact on that. We're involved in blood tests, ECGs and blood pressure checks as well. Any medication changes, so you'll have your traditional switches, but also very often the pharmacy technicians can flag up things that maybe a GP, if they're spending time with a patient, we can look at how we can reduce the impact on a GP's time and move that role somewhere else. Medicines reconciliation, we deal with lots of queries as well, and we've had a number of pharmacy technicians who, so I'll give you one example. We had one pharmacy technician within a GP surgery who identified a patient on methotrexate, and every 28 days their blood should have been tested, and when the pharmacy technician took over this role, they noted that the patient hadn't had a blood test for 7 months. So that was a huge intervention by a pharmacy technician. We can improve the pharmacy outcomes, and that's through patient concordance and adherence. I'd like to think we're the kings and the queens of the inhaler technique within pharmacy as a profession, and that's just one simple intervention that we can actually have on improved patient care, and obviously the impact on readmission into hospitals as well. More recently, obviously with COVID within the last 12 months, what we're now seeing pharmacy technicians doing, and certainly trainee pharmacy technicians doing, is supporting the vaccination programmes. So I do know of one area within the Northwest that are actually utilising pharmacy technicians to administer the vaccine under PSD, and we've also got our pharmacy technicians who are being involved in that as well. As long as the right procedures are in place, then the pharmacy technicians can undertake this role. Next slide, please, Liam. And this is just some evidence. This is quite raw data. We've got to build on this data a little bit more, but I thought it would be quite useful for you to see what's happened within a project within the Salford area. We have put 6 pre-registration trainee pharmacy technicians within a group of GP practices across Salford, alongside pharmacists. So they had the infrastructure in place. We've brought the pharmacy technician trainees in, and we've started to give them tasks. So all of those roles we've just talked about under supervision. And this is sort of 2-year data. We're having a formal evaluation on this, so a few of the universities nationally have put in for tender for evaluation of this kind of data. But if you actually look at where the figures are moving down through the year as well, I think the maximum that we ended up saving of a pharmacist time by implementing a pharmacy technician role was 22.5 hours a week, and that's just of the pharmacist. So if you think if we release our pharmacists, the saving on GP time as well. They've been heavily involved in being trained as well as a multi-professional team, and that's been really interesting for them because they've got to see how the wider team works, opportunities that they would never have got within secondary care, to be fair. And I think what's actually happened is we've seen pharmacy technicians, when they've gone back into the placements within the secondary care environment, they've started to identify patients coming into secondary care, and they know the bigger picture of the patient. And we've had certainly one of our trainees who has intervened on a number of occasions because they've known a patient because of what they've seen within primary care, and they've said, hang on, I know this about this patient, we need to think about A, B and C, and it's improved that patient outcome as well. So next slide please, Liam. So it's very quick whistle-stop tour really, but I think it's fair to say pharmacy technicians are the champions for medicines optimisation in all sectors, not just secondary care, primary networks. We've seen pharmacy technicians working in the past within PCTs and now CCGs as well. And I think certainly the raw data so far from our project demonstrates the value of pharmacy technicians, and now nationally there's been an influx of money to put pharmacy technicians within GP surgeries, within primary care settings, for example, community pharmacy as well, and using sort of tri-partnership arrangements to make sure they get the best placements and see the bigger picture of the patient. We've got a range of skills and expertise as well to complement the multi-professional team. I think one of the key things with the education and training of pharmacy technicians is we do get that clinical knowledge through our training, but there's also a huge emphasis on the practical skills as well. So we've got a lot of patient contact with counselling, for example. We're spending a lot of time out in those multi-professional teams, and we're actually seeing people now recognise the value of the pharmacy technicians. And again, it's all about improving that patient care and outcomes. I thought it'd be quite nice just to share with you as well, just based on that data that I showed you. Certainly in Salford, when it was half-term week one year, the trainee pharmacy technicians, because they were parents, a couple of them had some time out for school holidays, and within that week alone they had one pharmacy technician who was actually helping out, and they on their own were saving at least 10 hours a week of pharmacist time. And when they came back, they couldn't believe the impact by them not being there, and the GP surgery said we couldn't actually manage without a pharmacy technician, that we've recognised that value. So we've got, you know, some qualitative evidence there as well to suggest that the impact has been really positive. And as a result of the pilot, this group of Salford GP surgeries, they've actually decided they want a pharmacy technician permanently, at least one within their GP surgeries along their pharmacists. So I think we've got lots to offer. It's just about having the right infrastructure, the right support and the right team in place. So, okay, next slide please, Liam. If you do need any further information from me, please feel free just to contact me on the email. But we've also got a little bit about what we do within the pharmacy sector in terms of education and training, and what sort of opportunities are available to pharmacy technicians for their CPD purposes, and also some of the organisations that obviously we collaborate with. So we not only collaborate locally, but we've got lots of national links as well. So I spend a lot of time in national meetings working with national pharmacy colleagues about the best way forward. So if you do have any questions that you can't think of today, please feel free just to email me. Thank you, Liam. Thank you, everyone.
Thanks, Alison. That's an excellent presentation. Thanks so much. We've got a couple of questions in the chat, if I can put those to you. A colleague from Mount Road Surgery has asked, are pharmacy technicians the same as a pharmacist? So I wonder whether you could share the difference in the skill set and competencies between the two professions. Would that be okay?
Yeah, absolutely. So your pharmacy technicians are, the basic minimum training is to a level 3 qualification. Our pharmacists are educated to a master's level within pharmacy. There's lots of variation in terms of their clinical knowledge, but I think in terms of practical terms, we actually asked a pharmacist, what do you consider? So it's a pharmacist working in a GP surgery. What is the difference between what a pharmacy technician can do and a pharmacist can do in a GP surgery? And the response was actually very little difference with the right training and procedures in place. It was more around the medication review. So it was about the different levels of review a pharmacy technician could do in comparison to a pharmacist. And again, with medicines managers as well, people often say, what's the difference with a medicines manager and a pharmacy technician? Again, just from some of the roles that you see, we've got lots of clinical input. Traditionally, pharmacy technicians would have just done your basic switches, your lansoprazole or omeprazole type switches, which your medicines managers can do. But now we're building on that as well, and it is about the full reviews that patients are having.
Thanks, that's really useful. And there's a bit then, further bit in the chat around training for pharmacy technicians. Are you aware of any HE local or national funding to support pharmacy training?
I absolutely am, and that's my role within the Northwest. So every year we actually do call out for funding. So we've just requested funding for secondary care, and we allocated some funding towards integrated placement, so your cross-sector type placements for pharmacy technicians, and they're all due to start before the end of February. So there is annual funding available to that. You can get funding for the actual course itself through the apprenticeship levy, so you would have to go through your training hubs for further information on how to access that if you want to pay the salaries. But certainly from an HE point of view, we've had contributions towards actual training costs in terms of their salary. So there's been a contribution. I think it was 16.5k for the first year and 15.5k for the second year of the training. So you're getting a decent contribution there. And I think in terms of any contribution an organisation would have to make, from what I've seen, you would make those kind of savings if you just got your pharmacy technicians to perform audits and reviews. So there's lots of cost savings associated with that. So it is a really good investment.
Thank you. And a plug from the Training Hub. The Training Hub is also additionally looking at developing support for a pharmacy training programme. So linking in Alison and Rob going forward on how to maximise the best use of our resources, I think will be a great conversation to have going forward. Thanks so much for that. I don't know if Peter or Janet can answer this one, but how many pharmacy techs will the ARRS scheme allow us?
Shall I do that, Peter?
Yeah, if you'd like to.
Yeah, lovely. So at the moment, that is 2020-21, it's limited to one pharmacy technician between 30,000 and just under 100,000, and then an additional one over 100,000, except that with the agreement of the ICS, the CCG and the PCN, that can be increased. But we are looking at 2021-22. So the same restrictions may not apply then, basically. So we've got to, the network contract days will be published some point, at the latest on the 1st of April 2021. But we are looking at kind of the restrictions or loosening the restrictions on pharmacy technicians. And can I just plug the training that pharmacy techs get once they're in post in a PCN? So pharmacy technician gets a free place on a 15-month pathway. So it's the same in the main as the one that the clinical pharmacists undertake, not fully in terms of leadership, but yeah, so NHS England at the current time commission HEE to procure those places for the pharmacy technicians as well as the clinical pharmacists. So that's a free offer to them as well once they're in place.
Gosh, there's quite a few offers out there for pharmacy techs that we need to bring together in one place. So that is I'll
send you the link because it's a contractual requirement lead to for pharmacy techs that are funded under the Additional Roles Reimbursement Scheme in PCN. So it's a must do, basically. But I know somebody's asked where can they get access to it. So if I send you the link after this or during this, and then people have access to that.
Thank you, Janet. That's amazing. So really great discussion and opener. Thanks, everybody. Are there any final questions for Alison and around pharmacy technicians? Just a reflection. I've learnt a lot already, to be honest, actually, in terms of scope of practice. So yeah, thank you so much for that. Yeah. I wonder whether Kate is on the call and whether we could do an introduction.
Yeah.
Hi, Kate. Do you want to say hello?
Hello. Yeah, my name's Kate Catterall. I'm a physician associate workforce leader at HE, part-time, and I'm also a PA working in primary care. So I'm going to give you a quick overview about physician associates and how we fit into the ARRS role as well.
Thank you. Over to you.
Well, next slide, please. So what I'm going to do is I'm just going to start with a quick 3-minute video, really just to give you a flavour of what physician associates are and some kind of views of how PAs have helped in practice and in hospitals, just to give you quite good oversight. So if we can start the video.
So I'm going to share my screen now. I've just put the link in, Liam, if you want to stop sharing yours yet. I've just put a link in the video. Sometimes playing videos over Teams stutters, so if you've got another device, you might want to just jump on that link. But I'm just about to share my screen, and then I should be able to click.
A physician associate is a new healthcare professional who's trained specifically to work in medicine to deliver medical care to patients, and that means working in conjunction with the doctors to do that. Physician associates can work across the full range of healthcare, so you have physician associates working in general practice and in secondary care as well. So we have PAs who are working in paediatrics, we've got PAs working in general medicine, in surgical specialties, so across the full range.
I have quite a long history with physician associates, as I was actually a registrar at the time working with one of the original pilot schemes at St George's. So I've known PAs and PA students for some years. One of my missions was, to get PAs working in my trust because I could see the value in their role. The great thing for me when I've got rotating doctors or new doctors coming in is that they can really hit the ground running because the PAs know the logistics. One of the big benefits that we've seen is that level of continuity and consistency on a ward level.
As a trainee, I often spend time on call or on study leave or on nights or post nights, and actually that meant that there were long periods of time where I wasn't around, but actually the physician associates allowed patients to have regular contact and allowed the other staff members to have a regular point of contact. They allowed us to get more work done and they allowed us to do it more efficiently. I effectively treated them like I would any other clinical colleague because that's the sort of levels that they were working at.
Having a PA as part of the medical team really increases a patient's access to care. Having someone there who works as an extension of the consultants and the doctors in the team, we think the way they do, we work the way they do, we provide the care that they do in conjunction with them.
I've really enjoyed the job so far. It has been exactly what I thought it would be. It's been demanding and really hard, but at the same time I think the word rewarding is the best way to describe it. I really like acute medicine, and I think it's a big area of medicine where we don't have enough people, and I find acute patients generally they're quite scared because it's the completely unknown. They have no idea what's going on, and if I'm able to just kind of alleviate their stress and pressure a bit, I think as a physician associate I can do that quite well.
Since I started working as a physician associate, my role has changed dramatically over the 5 years that I've been working. I've been participating in clinic alongside my consultant, seeing patients off his list. I've also been participating in a plural list clinic alongside the other medical trainees with my consultant, learning about inserting chest drains and pleural aspirations.
I've seen how my own PAs that work for me have developed over a period of time and the things that they're doing that they would never have dreamed of doing when they first qualified. And I think those messages are what we need to take back from the faculty to, the wider workforce to say, look, this is what you can do with a PA.
Biggest endorsement of what physician associates do is the fact that actually in places where they work, they're popular, trainees like them, other consultant colleagues like them, and they realise that they add value to the team.
That's brilliant. Thank you very much. So I think what that really shows is really the breadth and diversity of what physician associates can do and how really they can be upskilled with the right support and supervision. So in terms of training and background, all physician associates will have a background in biomedical sciences. Some do have nursing degrees and sort of allied health professionals, but most do tend to have a biomedical science. This is just because you need kind of the pharmacology, some anatomy, some sort of science kind of deep understanding really to kind of bring you up to speed because the course is quite quick. It kind of builds on prior experience. So after that, the course is a really intense couple of year course and it's broken down into both placement and sort of anatomy, physiology, pharmacology as well. So as you can see, there's about 180 hours in community practice. There's quite a strong focus in general practice at the moment, and the number of hours have actually increased quite substantially to really get PAs working in primary care and show sort of where they fit in and provide that education. So after the 2 years of the course, then we move on to sit a national exam, which is both an OSCE at the Royal College of Physicians and a 200 question MCQ. And this is ensuring that all physician associates are coming out at the right level and at the right standard. So following on for this, there's two real options. You can either go into a preceptorship, which is your first year post-qualified, and this allows opportunities for extra training, development, supervision and mentorship, or you can go directly into sort of a midpoint band 6 or band 7 direct role. This might be sort of in a hospital rotational model or primary care and secondary care rotational model, or as a permanent member of the clinical team in either general practice or secondary care. And then after this, after 5 to 6 years, you've got to sit another exam, which is multiple choice exam. And this again is checking that you're safe to practice and ensuring that you've got a generalist medical knowledge. Next slide, please. So this is just a specific video. It's only a couple of minutes and it'll show really what PAs can do in primary care.
So again, the same thing. I put the link in there if you want to watch it on your device, and I'm just going to share and press play.
My name is Mohammed Hussain, and I've been working as a physician associate clinically for 5.5 years, nearly 6 years now. One of the reasons why I decided to enter primary care was the continuity of care that physician associates can provide. I'm able to get to know not just the patient, but their family, their carers, have that ability to follow those patients up. Along with that, the ability to work as part of a wider team. I've really felt embedded as part of the team here, working alongside doctors, nurses on a daily basis. They get a good feel from what I can offer and support, and also I get a good feel of how they can support me in not only my development, but also development of the physician associate role. My regular day would look something along the lines of attending the practice probably about 8:30, 8:45, checking up any results that have come overnight or over the last week. My clinics usually then start at 9 o'clock. Some of my days are predominantly focused around chronic disease, so I'll have more patients associated diabetes, asthma, COPD monitoring in the morning, followed by acute or minor ailment patients in the afternoon. With physician associates, we're trained quite generalist and we're taught to be very flexible, but working in primary care, you can really see that flexibility that the physician associate role offers. And so as a PA, we're able to provide that generalist care to our patients and then tailor our needs to the practice needs as well. You can direct the path in terms of how you want to progress your career, and that's the unique thing about working as a PA in general practice. You can start off doing, for example, minor ailments or the duty doctor emergency cases, and then from then on, if you start having an interest or wanting to develop a specialism, practices are very supportive in helping you develop that particular specialism. It's really up to you to determine your own career path, really. I think when you're actually in the role and you see the change, you can really see the difference that you make in patients' lives, you really see the difference that you make in the families' lives, carers' lives, but also the lives of your colleagues as well, because they really do appreciate your efforts and how you do improve service delivery for the organisation that you work for. It's really exciting actually, and it's a pleasure to be part of that.
Brilliant, that's great, thank you. So next slide, please. So I thought it'd be quite useful just to talk through my day-to-day life. So I'm about 2.5 years post-qualified. I graduated from Leeds and then went into a preceptorship in general practice. And from there I was taken on as a permanent member of the staff, and I work across a couple of sites at the moment. So day-to-day I start by looking at all the urgent bloods and sort of booking them directly into the clinic if it needs addressing, and ensure there's nothing really quite concerning that needs urgently addressing. And then at the moment it's all telephone consultations, so I'll do an acute clinic from about 9 till about 12 o'clock. And this is like any other undifferentiated clinic. In our surgery, we have lists for each clinician, whether GP, physician associate, A&P, and they're completely undifferentiated. So it could be anything that walks through the door. So it can be something as simple as coughs and UTIs, to something such as breaking bad news, palliative care discussions, engaging with mental health, acute mental health presentations, paediatrics, and working with social services if there's any sort of safeguarding concerns. Then roughly at lunchtime, we'll have an MDT, which I chair, and we obviously discuss all the complex patients. In our area of North Manchester, we've got high levels of deprivation and quite a lot of social issues, and so we work closely with the social services and the active case managers. Then I'll go on to do things like medical reports, DVLA reports and safeguarding reports. It just depends on what really comes on in the day. And during this time, I'll probably supervise an F2. We've got a trainee nursing associate who I may do some teaching with. And again, we have 4th year and 5th year medical students, which I've done my prime training. So I'm a supervisor to sort of support medical students and physician associates on placements. And then because of my interest, I've worked to be the diabetes clinical lead across 3 practices. So I'll sort of sort through all the higher, sort of the more complex patients with diabetes specifically, look at more complex management plans, initiation of insulins if appropriate, and try and look at a holistic review in terms of hospital management plans, how we can work out what to do with the eyes, and doing some patient education and taking a bit of time really to go through diets and sitting down with them and just offer slightly longer appointments. And I think it's quite useful because you pick up quite a lot of insight into the families, and then they kind of come back to you and you kind of see the benefits that you've had. And then outside of that, I might do things like quality improvement projects, the MHRA drug alerts, I'll do an audit and then do a protocol for the practice and inform the other members of staff. So that's something I take responsibility for any sort of drug alerts as well. So day to day, I do telephone triage. We do, just as any other sort of clinician would do, video consultation and ARRS, face-to-face clinical visits. We do home visits and care home visits too, and that's probably something a more experienced PA might do initially once I've had a bit more time within the practice and working with the team. But what I'm going to do is go into the next slide and discuss sort of where PAs fit into the ARRS role now. So the physician associates are completely fully reimbursed with the ARRS scheme up to maximum point band 7, which I'll come to later. And you can there's a few different ways of doing it. They can do sort of acute visits and they can sort of do some prophylactic sort of visits. They can look at assessing the unwell person and discussing whether for admission or to keep at home. They can work with the ACMs and the crisis team as well to sort of support management of the patient in the home. But they can also look at some sort of chronic disease management, advanced care plans, COVID care plans, mental health assessments as well. So it depends how you'd like to place PA, whether you want to do them partially used in general practice as you know the day-to-day, and I'll come back to the question in a sec, and whether you want to use them in care homes or just exclusively managing large numbers of care home beds. It does really vary from sort of person to person where you think the role fits. Next slide, please. So in terms of supervision, we do work autonomously, but we do need a supervisor. So that can be a GP or someone with adequate supervision. It's similar sort of foundation doctor sort of supervision that we recommend. And initially, if you've got a new PA straight out of university, they're obviously going to need a bit more time and supervision. PAs can't supervise, can't prescribe. What we do is we can put it through an EMIS, or we can print up a green script and have a discussion with our supervising GP about the meds. Day to day, it doesn't seem to cause too many problems, but it does rely on a really good relationship with your supervisor and built on trust. So what we recommend is the PA goes and talks to the supervisor and explains sort of the indication, any allergies, contraindications at all, and has it moved on your screen?
Okay, we lost you transiently for a couple of seconds, so you might need to go back rewind about 15 seconds worth.
Okay, where did you get to? Did I talk about prescribing? Prescribing. Okay, so we can't prescribe at the moment, and what we tend to do is go into the knock on the GP or send an EMIS sort of screen message, explain the indications, any contraindications, any relevant past medical history, and often the GP is quite happy to sign and review the notes. At the moment, it's going through GMC regulation, so hopefully by the end of the year we'll be fully regulated by the GMC, and with that in the next couple of years we hope to be prescribing. Whether that'll be an independent or supplementary prescriber, we don't know just as of yet. Next slide, please. So obviously there's a large number of growth in primary care. There's a push to increase hours for PA students to enter primary care, and there's different roles how they sort of fit in with a DES contract. I've talked about the GMC regulation this year, and I think that will change sort of the perception of PAs in primary care, and it'll make us a bit more independent. Hopefully when we do become prescribers, we'll also have access to requesting x-rays and ionising radiation, which is something we can't do at the moment, but we can do ultrasounds and MRI requests. And then hopefully we're developing the process of sort of a career trajectory at the moment to become more senior and take on more responsibilities, and that will be something GMC are going to be pushing for as well. Next slide, please. So in terms of what the benefits are for a PA, we offer continuity of care. We can offer holistic and proactive management, as well as looking at general medication reviews and management of chronic diseases. We can work purely in general practice or just with the care home population, or a mixture of both. And the advantage is that we can relinquish sort of time pressures for general practitioners to spend time on other patients prescribing. We've been shown that we are cost efficient, and patient satisfaction is equal to that delivered of a GP, and some evidence I can show about that, and we are 100% ARRS reimbursed. At the moment, the number of PAs isn't capped either in terms of that PCNs can recruit, and there's a bit of information on the HE website about the role of ARRS and PAs. Next slide, please. So if you need any support in terms of recruiting a PA or want some any ideas, we've got 5 PA ambassadors who cover the whole of the Northwest region, and these can offer some advice in terms of how to recruit, what sort of preceptorships, and they can also link into things with the training hubs as well, that offers they are in the process of developing to really support your PA into recruitment and beyond. Next slide, please. And here are some useful websites. Thank you very much.
Thanks, Kate. Appreciate that presentation. I'm going to just go on to the questions in the chat. The first one so a colleague has shared that they've looked into a physician associate, but they understood that the competence was similar to that of a HCA. I think what you've shared today is that the competencies are probably greater than a HCA. Do you want to give us just a summary of your main skill set? Is that okay?
So we're taught we do a Masters in Physician Associate study. So everyone's done 3 years of sort of rough, generally biomedical science, and a 2-year really intense clinical role. So 1 year of that will be virtually all clinical placement, and one will be kind of looking at all the medical management, safety, mental health. It'll be a very, very varied course. I work more at a similar level of AHPO junior doctor.
Okay, thanks so much. And you've quite nicely shared your position on prescribing, and as colleagues will know on the call, it is dependent on registration, and we're really confident now that the GMC is looking to do that in 2021. So it's long awaited, isn't it? So really pleased to hear that's coming on. Sam Howard from the Training Hub has shared around placements for physician associates. So as you've said, it's really important that as students, just like medical students, that colleagues do get early exposure in general practice. The Training Hub, the Greater Manchester Training Hub, does manage the placements in for physician associates from all of our local universities, Bolton, Manchester and UCLan. And as Sam has said, please contact Liam if you're interested in hosting a student. That would be amazing.
It's also try before you buy a little bit. If you want to sort of see what the role could be and how they fit in with your practice, it's a great opportunity for a few weeks of exposure as well.
Excellent, thank you. Janet, you had your hand up, please.
Yes, I was just going to say as well that there's guidance for supervision of PAs and other clinical roles and non-clinical roles in PCNs on the future NHS England and I's future NHS web page. So what I'll do is I'll send you that link, but it's also got access to lots of other great information that people can use for all of the roles, including physicians associates, including employment models. And I know we kind of discussed almost care in terms of directly employing PCNs, directly employing physicians associates, but there's other models as well that might work. So what I'll do is once it allows me on, I'll post that link and people might want to look on that as well.
Thanks, Janet. And in Greater Manchester, we do have support for preceptorship through the Training Hub, and there is a Lift 2 pilot going on in Stockport where physician associates and foundation doctors rotate through the programme, and we are looking forward to the results of that evaluation coming later on this year. And I think it would be really good to look at whether there are any other opportunities to work together from an employment perspective to maximise the delivery of the enhanced services through cancer or other programmes. So I think that's something to look forward in the future. Chris, good afternoon. You've got your hand up.
No surprise there, I'm asking a question. Hello. Thanks for 2 really good presentations. In Trafford, where I'm a GP, we've had experience of pharmacy technicians and they're really, really helpful. I've not had much experience of a PA, but I love the day in the life of a PA slide. My jaw was dropping to see how much you can do. And I just wonder how we can sell this to our very busy and exhausted PCN network leads, because they are juggling a lot at the moment. They have a budget, and how could we get something like the slides that Kate shared about what a PA does, and indeed what pharmacy technicians do, out to the busy PCN leads who are making decisions about who to employ next year, because I hope that their jaws will also drop and they'll be as enthusiastic as I am about PAs. And then the second thing is, I'm a trainer, and so I'm conscious that as a GP trainer, we're getting asked to train up more registrars, supervise student paramedics, supervise, and there's lots that we have to do. So again, on a sheet of paper to say to practices, this is what a PA student can offer, this is the income and all this sort of stuff, this is what a social prescriber, this is how much supervision a PA student would need per week or something, just so that GPs can make an informed decision, because at the moment I think lots is being offered and some colleagues might just be a bit like startled rabbits not knowing where to go. So some sort of neat for students, how much supervision is needed and how much income, sadly I have to talk about income for practice, but also then for the, you know, how much clinical supervision would a PA need a week? And if it's 3 hours, or if it's 1 hour, or if it's 10 minutes, then that can inform, I'm sure it's not 10 minutes, but that can inform what our PCN directors might choose to do. That was a long comment, but I think it's brilliant. We just need to sell it to our PCN leads. And if there's any PCN leads on the call, do they want to mention anything at this point? So.
Thanks, Chris. Anybody want to come in?
So we are working on sort of an AHP PA on a page at the moment. That's something that HE will be published in. We're just finalising that, and that'll be something really good to send out to the GPs. Natasha and I and some of the other AHP ambassadors and some of the other team are also working on a series of sort of documents that we can share for primary care as well, that will summarise how our roles fit together as well. So not necessarily this is a PA, it's saying how can we manage this patient, what specifically can PAs offer, what can social prescribers offer, into sort of a really short, succinct document as well. So there's a lot of work on at the moment to sort of disseminate this information rather than just kind of sending information and loads of long documents out as well.
Thanks. Janet, do you want to come in?
Sorry, I keep coming in there. Chris, one of the things that we're trying to do is make sure that the information that people need is in kind of almost one place or as few places as possible, and it's all in one. Everything that you might need might be there basically. So I've mentioned Futures NHS, and I now have the link, but there's also some of the work that the training hubs were doing, and so we'll look to see if the training hubs toolkit is still kind of still going, because what we did was worked with the national team and some of the local more local training hubs to kind of ensure that there is something that everything is in one place for how you employ somebody, recruit somebody, to the competencies, to the JDs, to everything can be found all in one place. Now, Futures is where NHS England is putting it, but we do work very closely with the training hub. So I'll post some information basically in the messages after the meeting, and so and as Kate said, anything that's new should eventually find its way into those two, hopefully into those two routes basically. So that just stops us kind of having to send individual things out to practices and PCNs.
Thanks. And in Greater Manchester we've got two sites for that same information. One is the Greater Manchester Training Hub, and second is the Greater Manchester Primary Care Careers platform, and we're populating both with matched information. So if you go to one place, it'll all be there available. Thanks for that. So, and Carol's posted our Training Hub website in the chat. So thanks for that, Carol. Any other questions for our colleagues? I agree, the presentations were great today, thanks so much. I wondered whether, Peter, you wanted to just share something about what's coming out nationally and when we can expect that next steps publication.
Absolutely. The DES, as I think Janet mentioned earlier, is in the final stages of being signed off, negotiated, confirmed, and everything. So hopefully that will be out fairly soon now, and we'll confirm exactly what's there. But we do know that the advanced practitioner level roles are going to be in there, and the mental health practitioners, as well as the community paramedics, the paramedics being in there. And as Janet said, we've got information about different employment models around those. So particularly with the level of concern with the paramedics about the impact on the ambulance service, we're looking at rotational options where people rotate between the ambulance trust and the general primary care, and the model for the mental health practitioners, which we're on the agenda to talk to, I think, at the seminar in 2 weeks. So we'll be back to share on that one. That's kind of a shared approach between us and the mental health providers in the area as well. So we'll leave that one hanging there as a sort of a cliffhanger for you to come back and get the update on next time. The all of the current roles, as Janet said, through the link onto Futures NHS, we have case studies, we have examples of employment packages and things that people can access. I'm more than happy to take questions, because we keep updating frequently asked questions as well to provide more information there. And we're working through signing off things like job descriptions and case studies for the roles that are being added from April. So do if you are interested and get the chance, take the opportunity to have a look at the information that's there already. And if there's anything that you think we can help with that isn't there, get back to us and we'll do our very best to provide what you need.
Thanks so much. That was a great update. Anything else from any others then? Any feedback for us in the please pop it in the chat, and I'm sure Natasha will share an evaluation with us. I've certainly learned quite a lot today, and I think following this there'll be quite a lot of resources that we'll pull together for everybody, and I look forward to the next one. Anything from Natasha or colleagues on the call?
Only just to say thank you to all the wonderful presenters. It's been a really engaging and inspiring presentation today. I've really enjoyed it myself. So thank you. And I'm just dropping in. Muted myself. I'm just dropping in the evaluation form into the chat. So if you please just could take a couple of minutes to fill that in for us, we'd really appreciate it. Thank you.
Thanks so much, and I would say if you want to hear anything again, both Alison and Kate have dropped their emails into the chat and can be contacted via anybody, any of our team today. We're really happy to come out and speak to you at your local practices, CCGs, networks, federations. So I'm really grateful for that. There's lots of training offers, education offers through the Greater Manchester Training Hub and through the GM Primary Care Careers website for JDs and employment support. So thanks so much for a rich discussion today. I'll see you all soon.